So I have 10 minutes to talk about SLC13A5 spectrum, and I focus on a couple of topics. One is I will give you an overview of the phenotype, but I also focus more on things that I think maybe we should focus on therapeutically, and then also how you would think about doing a clinical trial in like 50 kids all over the world, which I think is going to be a challenge. So I've tried to kind of bring up some thoughts on that. Okay. Oh, and you can stop me and ask questions, of course, all along the way. These are probably the highlights. These two are, I've actually only met in person four children with SLC13A5. I've seen videos and I've talked to families around the world, but these are the only other two kids I've met. And from knowing the kids that I do, there does seem to be a fairly tight phenotype. And this is borne out by the literature, which is that seizures almost always begin within a few days of life, probably the first 2 to 3 days. Interestingly, there's a completely normal pregnancy and delivery, so the kids' APGAR scores are usually quite high, meaning that they're healthy at birth. I don't know what that means as far as how the disorder is handled in utero, but it doesn't seem like these kids are seizing in utero, which I know sounds kind of weird, but it does happen. In retrospect, parents will often tell me, oh yeah, the baby was seizing throughout the pregnancy. So that doesn't seem to be the case. There does, however, seem to be persistent seizures of multiple types in most of the patients, not all, that is resistant to medications. There are distinctions in their speech, I think. The production of speech is much more difficult for them than their receptive language skills. So I don't know, is Colton coming today?
I think so.
Okay, so Colton, you'll see, understands quite a bit more than he's able to produce. And I think that has to do with a lot of oral motor problems, which the next topic is they have a very, kind of a distinct movement phenotype. And Colton will display that for you. But they have very low tone. Tone is your sort of internal stiffness. So I tell parents it's like spaghetti, you know, if you cook it too long, you get very floppy, but you know, you can be al dente and be a little stiffer. And they are very low. They have these episodes of body stiffening or weakness. It's sort of like one side for periods of time will become stiff or weak. And I'll go into a little bit of detail on the MRI in the next slide, and then they have these teeth abnormalities. I presume they also may have bone abnormalities because the mice have them. The mice have the teeth abnormalities, but as far as I know, there has not been any bone disorder described. This is probably, I think, the only paper on MRI findings in SLC13A5. And they're very non-specific. And what you can see is they're mostly in the white matter, so in these deeper areas, you can see these punctate white matter changes. They sometimes completely resolve, or they don't show this, but there are several patients that have completely normal MRIs as well. So I don't think the MRI phenotype is actually specific, nor do I think it's pathologic, meaning that I don't think it's the cause of most of the problems, since some of the kids have completely normal MRIs and still have the phenotype. Okay, so epilepsy and EEG features, early life seizures. There's one patient who is a little vague in the literature, maybe had seizures later in life, but I predict that maybe they just missed the seizures over the first few days of life. There's a wide variability in seizure type, severity, and frequency later in life. When I went through the literature and looked, only about 50% of the patients had frequent seizures, meaning on a monthly basis, suggesting that if we're going to think about a clinical trial, epilepsy may not be the only outcome measure that we can use. It appears in the literature that most of the patients remain on medication, though in the one study, the European group does report a couple of patients being off medication in early mid-childhood. But in most papers and in most experience from me talking to families, there is a persistent epilepsy phenotype, though it may vary greatly with frequency. So I just want to go over the EEG because I think I read EEGs constantly, and it is a little bit of a marker for the organization of the brain, the severity of the epilepsy disorder, but it's also kind of a marker of how likely are we to be able to affect the disease later in life for these children that are older. And this is TESS's EEG when she was about 11-ish or 12. And what you can see is that she has a pretty normal background, which is not true of a lot of the EIEs, the early infantile epileptic encephalopathies. This is a blank, but you see she can get a background posterior dominant rhythm of like 7, 8, 9 hertz. She does have a little bit of slowing, but it's not too severe. This is one of her typical seizures, of which she'll have a whole lot. And I reviewed an EEG of a little girl from Belgium, I think, France. Luxembourg, yes, thank you. And her EEG was identical to this EEG, which is interesting because Colton's doesn't look like this. But this is a myoclonic seizure. You see these high spike waves on both sides. And during this, it even says jerking head to the left. So it's not really like a lot of the other EIEs where the background is extremely abnormal when not having a seizure. And this is Colton's, and it's normal. His background, this was from just this last year, I guess. And he was probably four, yeah. And he has a normal EEG background. He is on seizure meds, and you can see that with all the beta activity, the passive activity. But my thought is that this indicates that this is sort of like a metabolic disease more than a structural problem or a profound progressive degenerative condition. I think that there's some hope that even kids treated later in life with some sort of therapy might be successfully treated.
So you keep saying it's not progressive, but I thought TESS actually regressed a little bit in terms of her skills.
Yes, I think when you have a lot of seizures, that is one of the things that happens. So I guess what I'm getting at more is I'm not clear on, it's not like a neuronal cerulopofuscinosis or, as a neurologist, like neurologists all shaking their head, yeah, you know what I mean? There are some of these EIEs that clearly the brain dissolves away. The kid's EEG background becomes slower and slower and slower. I don't think it's like that, but of course if you have a lot of seizures, I think there might be some regression, so I agree. Oops. So the thing I wanted to point out on Colton, so when he gets here maybe he can pray by and say hi. One is all of the kids seem extremely social. Like after having met the other two kids from India, and Emily actually has some videotape that she organized to show. I don't know when we're showing that.
Yeah, we could share that anytime.
Some of the kids are thanking you from around the world. And you'll see how sociable they are. They are super interested in what's going on around them. They're trying to communicate. They just can't do too well with it because of, I think, the oromotor hypoxia. They also have a very normal appearance in that they're, vital signs are fine, their head circumference is okay. They otherwise appear healthy. We don't seem to find any other disease except for the teeth, I guess, in the kids. They grow pretty well. Colton's on the skinny side, but he's otherwise seems pretty healthy and normal growth. He has a profound ataxia, hypotonia, which prohibits him from moving normally, but I understand he's walking even better.
He's making gains.
Okay. And you'll see, like, when you examine him in the exam room, he will have touched and grabbed everything in the room that he can possibly get a hold of. So he's super interested in what's going on around him. So that was some of the things I was going to describe. Colton was here. Yeah.
Do you see the difference between males and females?
So I have almost no experience. I have more patients, and then there may be, and this is sort of a gestalt feeling, but we would have to explore this more, and we're going to a little bit, is the females may have a little more severe epilepsy, but I think that's just an impression at this moment. I have no proof of that. Sometimes the second child seems to do a little better because maybe the neurologist taking care of the second one is a little more careful, or I don't, has some experience. But now, thanks to like Invitae adding it to their panel, a lot more kids are being diagnosed as the singleton. You don't have to wait for the second kid to be born. Okay. All right. Any other questions before we move on?
We can have Colton make a quick appearance whenever he gets here. So
Yeah,
we
he's
can see
super
it in
charming.
person. Colton is my son, by the way. For those of you who don't know, this is a really personal journey for me because two of my kids have this disease. And we use them because it's a small patient population. We use them for a lot of things because they're readily available. So EEGs, MRI, that kind of imaging.
So Kim and Brenda, Brenda, did you say that there are 50 so far?
Mrs. Nye has the best knowledge of how many patients she's collected.
Yeah, we need to track down more patients because we actually have heard about a lot of patients that we're not in contact with. So we're in contact with, what is it, close to 70, I think, at this point.
Yeah.
And there are more out there. And one of our big focuses, which Deepti will talk about later in the day today, is we're going to kind of make this the year of collecting all the information on all those families. And have a system
I just
in
wondered
place.
how connected you are with their neurologists.
So we keep trying. So
I've talked to a few. And I know some personally, we're not that big of a community. In the US, I know them better, but, and sometimes they'll email me, ask me things that might have worked for TESS or Colton, and they also give me feedback. And some of the things that I think have helped TESS and Colton don't seem to work in the other kids. So, or, I just don't know. So I think at this point, each neurologist probably only has 1 or 2 patients. And there does seem to be some variability in response. Even between TESS and Colton, I think there's been some variability.
So at this point, you can't say, for instance, that, because I think in conversations that we've had before, acetazolamide may have been one of the more effective.
That does seem to be something many of the kids are on.
And some of them had stumbled, so there's a family, for instance, in Brazil, and we ended up connecting, she has grown children, like 18 and 22 or something, that have this disease. And they had stumbled on acetazolamide themselves a decade before and stuck with it. It's stories like that that suggest it's not just us feeding the information to the families that it might help, like other people think that this has helped their children. You can sometimes tell by what people stay on, because they just try a lot of drugs.
And is that the only one that seems to be consistently helpful?
It seems to be the one that I don't hear like, oh, we tried that, it didn't work. I don't think any of them work great, so people are kind of like, well, maybe this helped a little bit.
Siblings are on different medications, right? So even 2 kids with the same mutations take different medications. So there's not a clear winner in terms of treatment options from the talking to other moms perspective. I think that the most effective medications that I hear from the other moms is phenobarbital, Depakote, and acetazolamide. And it's hard to know whether those are, the best working or just the least expensive, or it's hard to know.
Was the zinc effective?
Well, the zinc is an interesting story. I think this is broken, Emily. Okay. I'm sorry. Can you hear us with just your regular mic?
That's fine.
You tell your zinc story and I'll add anything.
Okay. So we tried zinc just because it seemed like a fairly safe thing to do, and we saw a marked decrease in my daughter's smaller seizures pretty immediately, and by marked maybe 70% less.
She had 100 a day at least, so it was kind of a big number to see look for the decrease.
But it sort of tapered off at some point where they started to increase, or she started to have like clusters of seizures that the overall, she would go longer periods between seizures, but then she'd have like 50 seizures in a row in a 1 hour period or something. And so it was a weird experiment because it did something and then it didn't, and it's hard. We have that happen all the time with seizure medications, but it seemed more surprising that it happened with zinc.
And Colton didn't touch his
It
tongue.
didn't do anything, yeah.
Colton,
But he doesn't have seizures, so.
yeah, his seizures, he doesn't really have them. I couldn't even remember the last time he had one.
Yeah, he had a febrile seizure in February or something.
Okay.
That's-
So again, these are so anecdotal that I feel like at this moment we don't, I don't know what to say about which meds work or not. JoJo's working on this questionnaire we're gonna try to send out to everybody across the world, where we ask them a lot of questions about their meds, but then also we do this adaptive behavior analysis that the parents can fill out so that we get some kind of baseline abilities and compare those to a bunch of different things like their seizure burden, their medications.
So from what you know so far, in talking with other families, is the hypotonia that's the most consistent?
Yes, every single child has hypotonia and trouble producing speech, with maybe the exception of one woman in Germany, right, who does seem to speak.
So is the hypotonia more consistent than seizures?
Yes, it appears to be in my crude, just talking to people. So that's why JoJo's actually, we're using this Vineland adaptive behavior rating scale, which gives extreme detail about their abilities. It's not from a neurology exam perspective, really. It's more like the kids can do this or this. But we couldn't figure out a way to standardize 70 neurologists doing the exam or the money to do that. So. Okay.
And just to clarify, every kid starts off with a seizure, like
Right.
that is consistent. So seizures are the first symptom that everybody sees, and it's usually within 24 hours after birth.
But then as they age, some of their seizures stop, or they're stopping because they're on medication, or it's unclear?
I think there's 2 kids not on medication.
It's rare to be off meds.
But all the other children are on multiple seizure medications, and some of them gain seizure control and some of them don't.
Yeah, that's the confusing part. The burden of seizures is very varied and the type of seizure is varied.
So no hypotonia at birth, that's documented.
You probably, I don't remember, I examined Colton, but by then he was on a bunch of meds. He was breathing okay right out of the bat. Their APGARs are 10 and 10, like often. Nobody gets a
But
10, I don't know.
pretty early on after seizing, they're getting phenobarb loaded, so it's a little hard to tell.
Oh, yeah.
But having such a high APGAR score right off the bat, that is part of the APGAR is tone, so.